So I'm Jeannie Miranda from UCLA, and I've been working in the area of cognitive behavioral therapy with low-income minority patients for many, many years. So I'm going to give you an overview of CBT, just a brief one, to just help you understand what it is. How many people here have experience with CBT? Already have done it? Quite a few. So if you need me to step it up, let me know if there's a lot. But we'll just kind of let people know what CBT is. And then we're really lucky to have Pamela and James, I'm going to let them introduce themselves, who've been working with it in a community setting in your community.
Yeah, hello. My name is Pamela Sandras, and I work for Behavioral Health Services, and I've been a part of the Project Bright for the last 4 years, facilitating CBT to clients who suffer with depression.
And I'm James Thompson, also work for Behavioral Health Services. And like Pam, got involved with the Bright One program and learned how to facilitate CBT inside groups with clients with depression and substance abuse concerns. Found it very rewarding.
And then we're really lucky to have two people who trained with us at UCLA and are going on. One's still a postdoc and one doing great things at RAND. So I will let them introduce themselves, but both of them have a tremendous amount of experience, including doing a major and important project with CBT for folks who are depressed following Katrina in New Orleans.
All right, can you hear me now?
Yeah.
Great. I'm Vicki No. I'm a clinical psychologist. I worked at UCLA and trained under Jeannie for 3 years, actually. I'm very interested in rolling out CBT in ethnic minority communities and figuring out ways to support it in community settings. I've been working in New Orleans actually for the last year as part of a Red Cross effort to support clinicians in New Orleans after Hurricane Katrina. And so I've been very lucky to have had that experience. And I worked with Judy on that.
Hi, my name is Judy Ho, and just as Vicki mentioned, we were both working on that Red Cross project, the regional project that was working with the low-income population in New Orleans, and that just wrapped last month. I've been working with Jeannie for 2 years now, and really interested in working with ethnic minority populations and low-income populations and how to provide the best treatment. I'm really excited about this project, and nice to meet all of you.
Terrific, thank you. So we'll get started with a little introduction. I do want to say that part of a team we have here are sitting at this table over here. Will you guys raise your hands? These are a wonderful team we've been working with at UCLA who we know that a lot of people who have diabetes become depressed, and so we've actually combined a CBT treatment with an empowerment project to make both diabetes care and depression better. So they have some great experience. Have been really fun to work with. So I want to just give you an overview of cognitive behavioral therapy and what it's about. First, to convince you, talk about the literature a little bit. It's been studied a lot, and then introduce you a little bit to the manual that we use to do this treatment. So there are several kinds of treatments for depression that have been shown to be quite effective. So for psychotherapy, cognitive behavioral therapy, interpersonal therapy, and behavioral therapy or behavioral activation have all been shown to be effective. When you compare them, for CBT, there have been 325 published outcome studies now, so it's really been very well studied. Cognitive therapy has been adapted for a lot of disorders. It's generally structured, so unlike just open-ended therapy, it's quite structured. You have a certain number of sessions. You're to cover a certain number of things, and it's fairly short-term, 12, 16 weeks. I think it's difficult to learn. I think it takes, our team over here, we've struggled. You have to kind of get it for a while. It's a different way of thinking about things to help people challenge whether their thoughts are correct or not. and if there might be more adaptive ways to think. So it's a little bit difficult to learn, but very effective. And in the 75 clinical trials that focus just on depression since 1977, and in all of them they show it's far superior to weightless control, it's superior to a placebo, and it tends to be superior to just psychodynamic psychotherapy in terms of treating depression and depressive symptoms. It's equal to behavioral therapy, and it's equal to medication. For all but the most seriously depressed, it tends to do just as well as medication. And I think a lot of even therapists don't know that. When I've gone around doing trainings, they say, oh, I would only do, if somebody's depressed, they need medications, I would only add this on. The truth is it's about equally effective to medications for treatment. The combined mostly doesn't do any better if you give people both medications and psychotherapy than either one alone. So for the most part, we consider, just because you have side effects and costs for both, that it's probably good to just do one. Increasing evidence suggests that a really nice thing about CBT that isn't so true for medications is it tends to prevent relapse. So we all know depression is a recurring disorder. And if you have a course of CBT, you have some tools to use, and people are less likely to relapse, which is very nice. So the main ideas of CBT, the first one is that dysfunctional thinking, or the way you think about the world, can predispose you to depression. And some studies we were involved in many years ago really show that what happens is, if you're not inclined to be depressed and something bad happens to you and you feel sad, your thinking remains fairly similar to what it would be if you're not sad. So you see the world fairly clearly, but you're just sad. For people who are predisposed to depression, what happens is something bad happens, they feel sad, and then their thinking betrays them. So at that point, the person who is adaptive, let's just use an example. So I had a friend many years ago when I was in college who was engaged. She was coming home. She was all excited. She was going to get married. We were all excited to get to see her. She came home and she said, well, we called off the engagement. And we were all expecting her to be incredibly upset, and she was sad. She was definitely sad, but fine. The way she was thinking about it is, she said, I came this close to finding the right guy. I just know he's out there. Next time I'm going to do it right. So she had the way that she conceptualized it was she would be fine. People that you treat with depression might say, oh, if he doesn't love me, there's something terribly wrong with me. No one will ever love me. I'll always be alone. So if when you get sad, you end up with those kind of thoughts, it drives your mood further down. It drives your behavior to behave in ways that you're not as likely to be out there meeting new people and feeling good, and it spirals down into depression. So the idea behind CBT is to help people identify those thoughts. And I know Ken showed that little book of Think Happy Thoughts this morning, and I'll tell you, that is not what you want to say to somebody who's depressed. They feel bad. They get so mad if you try to say, think happy thoughts. That's not what we try to, but we try to say, let's evaluate the thought that you're having. I'm a terrible person. Is that true? Is there nothing good about you? Can you think of good and bad? So it's helping people evaluate their thoughts and come to oftentimes a more reasonable thought that can help improve their mood.